Whenever in doubt, ask the patient to breathe in, take a deep breath so that you can see if the membrane is breathing or not. Especially before we start grafting. That's the time we always check very clearly if the membrane is breathing or not. The posterior area is very, very easy to lift up because you can see it. The anterior area is the blind zone. And now we have very small mirrors because I'm also an endodontist. We have micro mirrors which we can actually put inside the sinus. And it's a great idea to have really small mirrors or pediatric mirrors to be able to visualize the anterior part as you raise the membrane. Trying to do it blindly with just the feel is what you can achieve after a couple of hundred sinus layers, where you can claim the tactile. But until that time, it's best to see it. I think it's best to mention at this time that you need a great staff, you need great assistants, and the team we have in our practice has been working with me for over 10 years, and they are doing a fantastic job, I feel, because they are my stress busters. So you can see the entire membrane is now palatal. You can see the posterior septum, and you can see the entire floor. Unfortunately, I won't be able to show you the anterior part, otherwise because we need a fiber optic camera for that. You can see the posterior and you can see the base. The membrane is still breathing. With just a single periostal elevator in the sinus, we are holding the membrane. And I guess this is pretty much it. We've raised it as far palatal as we can go. Now, sometimes we imagine the sinus to be much deeper than it actually is. When you open the Peponi window and start raising the membrane, because you can't see far palatally, you feel that that membrane is infinite. It's not. It's just maybe 5 or 6 or even just 10 millimeters to the palatal wall of the maxillary sinus. So it's not that deep. In this particular case, we use EasyGraft Crystal, which is a graft from a Swiss company called Guidor. The only reason we are using this graft for the sinus is that it comes with a liquid called the BioLinker, which you mix with the graft material, and within about 2 or 3 minutes, the graft sets like rock hard sets, and that helps us manipulate the sinus much better, pack the sinus much better. So our choice of material for the sinus currently is the EasyGraft. And you will see why. It's just simple mixing. Put the BioLinker into the powder, let it mix for about 30 seconds, and it's ready to use. Sorry for this. And I saw the lineup today. Dr. Mayekar, Moiz, Dr. Navre, my guru, is going to follow. I said it's best if I kept it to a video rather than keeping slides and talking about them all the time. People can just relax and enjoy what they see because it's going to take a long time to talk about this. It's best to show it. You can see we are holding the membrane with one single periostal elevator right at the palate. And then as we put the graft in, the graft just stays. It goes in like a putty and just stays there. You can actually condense it, mold it, give it whatever shape you want, and the shape we give it is just to compress the membrane against the palatal side. And then the graft just stands up there like a wall. And the entire sinus lateral to that is available for you to graft with whatever material you want. In this case, we use a single material, but if you wanted a hybrid technique and you wanted to get in with some other bone inductive material, you could do that. But the idea for this graft was very simple, that you just condense it against the palate, against the membrane, and it just stands there. As it mixes with the blood, it becomes hard, very hard. You can see all this space here, about 5 or 6 millimeters of space. It's just like that, it's going to stay like this.
And what are the grafts for?
And the idea is the graft sets so hard, you can touch your Hyvax suction to it. Nothing moves.
Are they putting bone there under
It
the
just stays
sinus?
there. It's not going anywhere. You see how the consistency is and why we don't need a membrane on top of this bony window. The last increment of the graft that goes in is just standing on the bone there. So we like this for the sinus, but as literature will tell you, as research will tell you, as evidence will tell you, anything works in the sinus. Okay. So our success has got nothing to do with the graft materials we are using. It's just evidence-based stuff. You can see that it's just standing there, it's not going anywhere. You can just condense it and keep condensing and keep condensing and keep packing the sinus. So we've packed up the sinus anterior to posterior for about 35 millimeters. Sorry, 35. About 20 millimeters from top to bottom, because we expect about 20-25% consolidation over 6 months, even some resorption. And we need about 11 to 13 millimeters of bone for the implant placement. Because we are going to submerge the implants by about 2 millimeters. We need at least 13 to 15 millimeters. So expecting the 20-25% consolidation, we are going for about a 20 millimeter height raise or a 20 millimeter lift, as we call it. So the elevation has to be about 20 millimeters. You can see the graft is just sitting there and sitting tight, not moving. You can just touch your suction to it and just the blood comes up. So that's about it. That's the grafting. You'll see in a few seconds the CT scans after the grafting to show us how much we built up the sinus. Of course, the suturing need to close, must get primary closure. You didn't see the vertical suture, but that's how much we built up the graft. Now this is the septum anteriorly and that was the septum posteriorly. So we didn't break any septums, we didn't need to. But the entire sinus from top to bottom and from medial to lateral is completely filled up. So we're done with the sinus grafting. We wait patiently for 6 months. For this particular graft that we have used, we know from histomorphometric evidence that about 30 to 35% new bone formation occurs in the first 4 months. In 6 months, I expect about 40%. And at 40% new bone formation and 20-25% consolidation, I have enough bone. I have enough bone histologically, new bone to be able to place my implants. That's why we go in after 6 months. Why don't we go in immediately? Because we wouldn't have the stability to immediately load it. My patient comes for teeth. And earlier we used to build up the sinus, then put the implants, then wait again, then wait again. I'd like to reduce it and reduce the time. And where I can reduce the time is loading after placement. I will not be able to place the implant successfully, predictably with such less bone, but I can definitely load them when I have good bone there. So if the reconstruction is good, you will get good implant stability verified with ISQ and RFA measurements. And if you have ISQs of about 70 or more, it's no problem, you can just load them, especially with welding, and we'll see that today. Pretty much same, no vertical incision this time, just the supracrestal, mid-crestal incision. This is just implant placement. I think this music was playing when we were placing the implant. You could use a surgical guide if you want. The idea is to properly position the implant and then place them all parallel. Because we are going to give a tonometric supported titanium reinforced resin restoration immediately. We need the implants to be as parallel as possible. Dead parallel if possible. First the positions and then the drilling parallel to each other. So let's just see it. Because it's a grafted sinus, we're using one implant per tooth. Because we're immediately loaded, we're using one implant per tooth. And just as a general principle, we're using one implant per tooth. You can see the resistance to drilling. These are the areas we have grafted, the 5 and the 6. It's tough to drill through this bone. It's not very easy. We got insertion box of about 25-20, which was not bad. Our RFA readings were about 70 because that's the reason we loaded it. I'm sure everyone here is placing implants, but if there is that thin population that isn't, this is how it's done. With Ankylos, it's very simple. It's just 2 drills, and then the implant follows. We have the inherent advantage of the connection with Ankylos, where it's a conical connection that allows for a superb horizontal biological width management principle.
Sorry to disturb you.
The challenge really in this case was to be able to accommodate those portions. We have just enough space. There is some mesialization of the third molar. We have very little width buccolingually, just enough to be able to place 3.5 millimeter implant. That's also another reason why it's per implant, per tooth one implant. For a molar implant, it is said it's best to place implants which have a width of more than 4 millimeters. But if you don't have that width and you need another reconstruction with horizontal block grafts just for the width, that's going to take another 6 months. Ankylos, there is enough evidence out there to suggest that you could replace an entire molar with a 3.5 millimeter width implant because the connection is so strong. The abutment connection, the principle of the bone. As a general principle, I do believe myself all time to place the last few threads with hand. Technology has gone far forward now, but I am a little technologically challenged. I still use my hand to get the feel of the implant. If it's going in properly, maybe even change the direction a little bit, because with the motor it's easy to get carried away. It's got high torque, high speed, the implant is going in, everything is feeling right. At the end of it, we find it's not parallel. It's difficult to then remove it and put it back. So sometimes when we need dead parallelism, we choose to put it with the hand. And that's the reason you're seeing it like this. I believe that in teaching, like my teachers, like Dr. Meshram, everyone who's spoken here except Moise has been my teacher or is going to speak as my teacher. And the only thing great about all these people is the conviction. And that conviction comes from honesty. They show what they do, right? And that's the reason we've chosen to use the video. This is real time. Whatever you're seeing, this is what we do. So these are not selective clips or selective pictures. This is what was actually done. So that you can believe it works. We have the fourth implant in the last one. Idea is to submerge the implant. Ankylos has the principle you need to submerge it by at least 1.5 to 2 millimeters. So we are submerging the implant. It's an incredibly simple system to use. Even with the maxilla, the grafted maxilla, where you can expect D4, D5, sometimes even D6 bone, we are able to get good insertion torques with Ankylos. This is the point where I believe all the change will take place in the future in implant dentistry. This is where everyone is focused. How do we load this immediately? How do we functionalize it immediately? How do we let the patient eat on it, use it? Aesthetics, occlusion, biting. The patient wants to enjoy all this immediately. And we are getting ambitious, honestly speaking. Sometimes even too ambitious. We just want to load this. We want the patient to start using what we are putting in his mouth as soon as the patient can and as soon as has become immediately. And I believe that's a good step. As far as the patients are concerned, from the patient's perspective, I think it is incredibly important that the patient can eat, especially in full arch rehabilitations or full mouth rehabilitations, where the patient is on a denture for 90 days minimum. I mean, imagine eating with dentures for 90 days when you're used to eating with your fixed teeth. It's very difficult. On a surgically operated site, the denture lies. So immediate loading is a concept which has taken off and is doing well. We are getting ambitious. So we have this pre-formed, pre-prepared, simple acrylic bridge that was prepared before. We are going to now put in our abutments, the standard abutments on the anchulars, and use the weldable copings which are friction fit, no screw, no cement. They just fit because of the goniometric principle. So these are the temporary abutments that are coming out. We took a putty index in the preformed acrylic teeth that we are going to bridge that we are going to give to the patient so that we have a gauge to bend the titanium wire that we are going to use to weld. So these are the standard abutments that have gone in. You can see the implant is submerged. The standard abutments are now in place. The putty index with the mount or the implant head gives us a guidance for bending the wire. Now for such a small bridge it's not a big deal. Bending the wire, which is about 30-35 centimeters, is not a big deal. It's not a real big deal to do this. Bend the wire, be able to match. It's not a very difficult thing for this case, but if it's a full arch case, if you want to start bending a wire from molar to molar inside the mouth, it's going to be very difficult. So the same principle can be used for a full arch case for bending the wire. These are the weldable copings that have gone into on the standard abutments. We're just checking how far they are from each other so that we can decide what thickness of wire. So as a rule, if the distance between the two weldable copings is more than 15 millimeters, you need to use a 2 millimeter diameter titanium wire. If it's about 10, then you can use a 1.5. So here we use a 1.5 millimeter diameter wire. These are the pliers that come from Mustomed and the cutter for the wire. You remember the putty index we prepared. So that's how we are going to bend the wire. Very simple for this case, just a straight. They're all in one line, the implants. Just a little bend will finish the bending. For a full arch case though, this bending will be more complex. What we are really doing is just resistance spot welding, okay, wherein you're putting pressure on the two metal surfaces, then passing a current. You have what is known as the nugget in between, which will weld the two sheets together. Very simple. It's been happening all the time. Okay? So dentists earlier were tailors, then they became carpenters with implantology. Now we've also become welders. The only challenging part about welding is this: to be able to hold the wire for the first weld in such a way that the wire contacts all the weldable copings at the same time. If there is a space between the coping and the wire, then there will be sparks, big time sparks. It will be Diwali in the mouth, which you don't want. There's a lot of fireworks if there is a space. So the basic idea is to really have the first weld that goes in such that the wire is contacting all the copings. Once that has happened, you just need to put in the welding electrodes and weld it up. Now you must be thinking there will be sparks, there will be smoke. Nothing of that sort happens with the weld-on unit that Dentsply is providing. You don't get any bad smell, odor, smoke, sparks. a patient and their relatives, sometimes they are in the operating room, they feel now they're going to see the welding. You don't see anything. It just welds. It takes about 2 seconds and that's it. The wire just welds and it welds. Okay. We still use the wire, we still use water from the 3-way or the saline if we can. Whenever it's an open surgical site which is not sutured, we prefer saline which comes straight from the physio. So you have the welding, the copings are welded. Now the conometric fit is so good, this doesn't come off easily. You will see that we are using a spring-loaded crown remover to take it off, and it's still difficult. Okay? So there's no cement, there's no screw, the fit is too good. It's difficult to remove this. It will pop off eventually, but it's not easy. So my patient, when he walks away a few hours later with this restoration, I'm not worried about whether it's going to come out, whether the cement is going to debond, whether the screws are going to get loose. Nothing of that sort happens. Because with a temporary restoration of an immediately loaded implant, the stability of that restoration is very important. You should not have screw loosening, you should not have cement debonding on either of the implants. Any of the implants at any time. And that's where we can't trust the cement. That's where we really cannot trust the screws. But the conometric fit, perfect. So we've roughened it up a little bit, added an opaquer. Moy spoke about occlusion all the time. So you guys, we're a bit lucky for this case. He doesn't have lower molars, doesn't have the lower 6. But we're going to restore that. It needs a tunnel for the lower one. We will do that too. For the time being, what we're trying to do now is to try and fit in the copings properly, so we tap them, just 1 or 2 taps and dip it into position. Because when we acrylize this temporary bridge with the welded wire and the weldable copings, we want the coping to be in perfect position. We don't want the coping loose, we don't want the bridge not fitting over the copings. And to make sure of that, we need to really tap it inside. Once it's inside, we can acrylize it. Sometimes when we are not sure, we take an OPG during the time that we are doing this, just to make sure that the copings are in place. Especially when there are 6 or 7 copings for a full arch, generally take an OPG. The material you saw that was being used is just composite. It's self-cure, dual-cure composite. You could also use mouth acrylic if you are going to give this only as a temporary. If you are planning for this to be the final definitive restoration, which it can be, then you could also use mouth acrylic, temporary mouth tooth-colored acrylic. And we do that frequently for full arch cases, where the patient desires a ceramic restoration at the end. We use mouth acrylic, which is tooth-colored, for the temporization. Because we want the temporary to last for a couple of months, maximum of 3 to 4 months, and the acrylic can last that long as the wire inside is titanium and it's welded. So we have enough evidence to show that this welded wire and coping is much stronger than your castable hybrid. It's done intraorally, so the fit is not an issue, it's just fit in the mouth. Whenever you do a castable, you are taking an impression or casting. There could be some errors in the fit. Sometimes you have to solder the casting. There are no such issues with the welding. So our temporary is ready. It's ready to go in. And increasingly now we are beginning to believe this can be the final restoration. Patient can just use this all the time. The standard abutments, suture cover it up. It's really good to have a technician handy. If you have your own laboratory in the clinic, it's great. But otherwise, you could call in your technician for a couple of cases so that he knows what to do, and then maybe he can be there on site to help you deliver a completely finished polish restoration. Or you could train one of your assistants to do this. Now, practice, we have a technician who does this. Initially, of course, you have to do it yourself. Again, a little bit of tapping so that it goes into place. Check the occlusion. I don't need to say anything about that. We just make sure that it's not high. Okay? There is no elaborate occlusal adjustment. We try to see that there is very, very little contact. Okay? It's important in life to have the right contacts in every sense. Okay? So at the right contacts in the right place. Luckily, we don't have a molar here. This side also needs horizontal grafting. You can see that the occlusal table is pretty much flat in the acrylic teeth, so cuspal inclines are shallow. Also, at the same time, we reduce the occlusal table, especially in the posterior area. We don't want eccentric contacts on this for the next 2 months. 8 weeks is where we don't want anything eccentric. That's the scan after the surgery and the loading. You can see we have good length of implants, sinuses, stable. This is how it was when we started practically no more. That's when we grafted it. That's how it's going to look when we finish. So all in all, I feel that I came across this HSBC ad while I was traveling somewhere. It was at the airport, and I looked up the history. So this is Volker Kraft. He is a very senior gentleman, 75 years plus, with he and his wife. Every Easter, for 2 weeks, they spend 2 weeks before Easter trying to decorate the apple tree that you saw, which is there in their garden, and it's decorated with 10,000 handmade Easter eggs. You know? So a lot of people around the world, clinicians, researchers, material scientists, they are taking a lot of effort to try and see if they can make graft materials, techniques, implants, implant surfaces, so that we can place and load these things immediately. So that's where it's all headed, and that's where we like it to be, because our patients like it. It's also convenient for the patient. And so today's presentation was just about trying to convey that such things are now possible. This is what we do all the time. In the practice, it started working, and in truly, I feel, is the story of human ambition. We are ambitious. We want to start doing things immediately, and I feel that with welding, intraoral welding, that with these kind of graft materials and the techniques and the science and the evidence, the information flow that is available, is going to be possible increasingly in just everybody's practice. So thank you very much. I hope that I didn't bore you.
Not at all.
I just wanted to have a simple movie, no slides, no text slides, no talking, so that you can just sit back and enjoy, and also take a nap if you do. So thank you very much. Thank you for having me here. I think, are we delayed for lunch?
No.
No? Okay.
Thank you, Dr. Nikhil, for a wonderful presentation. No slides, but real-time video. And that is what makes a difference. It was a wonderful presentation. The concept what you put, welding, in this part of the world, I for the first time saw how you can achieve the best possible results with that. Till this time, I have only read, but I have not seen any case with intraoral welding where you can achieve the results. It was really fascinating presentation, wonderful presentation, and thank you very much for your effort. On behalf of ITA, I have got great honor in presenting to you the certificate of appreciation. We are practicing Malad.
I know what I want to ask you is, first of all, I'm just a graduate and I'm graduated from GDC and I don't do implants. So the questions that I'm going to ask you are very basic.
Yeah, that's all right.
Okay. Firstly, the video was a great idea. I love it. Okay, first thing. Second thing,
What else can you do? If I keep talking slides, people
no,
will
this was
see.
very nice. I know, but what I'm saying now that background music which you had now was not the usual dental clinic music which is
No.
very soothing.
No.
This was really scary for me.
Yes,
Okay.
because you don't want people to sleep.
Okay.
If I keep instrumental,
Yeah, my patients used to
sitar,
sleep. My
tabla,
patients used to sleep.
patients sleep.
Yes,
Now, the
yes.
music you saw in the video is not what plays in my operator.
Okay, that was just a
The
background
music is put on the background
Okay,
so
okay.
that people here don't sleep.
Okay.
I like it if my patient sleeps.
I thought it was in the clinic.
Yeah, and sometimes we do use
Yes.
what
Hindi
should I
music.
say? No, something the patient likes. We
Okay,
have somewhere,
okay.
we have a pod where he
DJ.
can put their own phone, listen to
Oh,
their own
okay,
music
okay,
and
okay.
stuff. This patient was a nice guy.
Okay.
He said, do what you want.
Okay. The basic thing I want to be, I don't know much about the sinus lift, so what I'm asking may not make sense, but I still want to ask you.
It will make sense,
No.
yes. He will make sense of it.
Okay, okay. Now what I'm asking you is when you lift the sinus, no? You're lifting that
Yes, thank you. That was great. I was listening from outside. Don't mind that. Blockbuster, everyone. बाहर से लोगों को भगा रहे थे. मैंने कहा भगाओ मत यहाँ से देख. But it was good. I'm glad that you've taken up the topic, which is so difficult to convey. But I felt that it was a very good presentation in terms of being able to convey occlusion. And nobody is doing that. So all the best.
I will attend that. I have to ask him for that.
He will do it again.
Okay. Now what I'm asking you, know that so that sinus when you lift it, no, the wall of the sinus is like a mucous membrane, no?
Yeah.
So that you lift it upwards.
Yes, it's like periosteum.
It's like
So
periosteum.
instead of a flap is much thicker.
Okay.
Imagine half of that
Huh.
with about 4 times more delicate.
It's very delicate.
It
Yeah,
is
and you
delicate.
can perforate it
It is
also.
delicate unless a patient is a chronic smoker, then it's pretty tough.
Okay.
And it's
And you
possible,
make-
but I wouldn't put a sinus graft in a chronic smoker.
Great. No, you're a prosthodontist, no?
No, I did my master's in NYU in implantology.
Wow.
I'm
But
not
Dr.
a
Mishram
prosthodontist.
is your professor.
He's been teaching everybody, you know how.
He taught me also.
Yeah, so
He
he's
taught
been
you
in GDC.
BDS, you mean?
Yeah.
Huh,
Was
even-
the
he
lower
taught me
graduate.
also.
But I'm a NIRite, so I'm not from GDC.
Right, okay.
But we've been, Dr. Ram was here, he was here, they're all from GDC.
Yes.
And GDC Nair was only the stuff before.
Yes, yes.
There was no DY Patil there.
Correct,
and
correct.
All those other colleges that have
Correct.
come out. So these teachers are a very close circle for us.
Yes, yes.
So, and he's still around. I mean, I don't think I'll survive this long.
Doctor, what I'm saying, so then you packed it with bone graft.
Yes.
Yeah. But what I'm saying is when you do that, you lift the sinus and you pack it with bone, doesn't the sinus width reduce?
It does.
So
The
that is-
sinus, yeah, see, we will try to imagine it the other way.
Okay.
We lost bone in the sinus,
Yes.
first of all. So there was bone in the sinus.
Yeah. So,
So how much bone was there?
initially the diameter
So
was
how
less
much
to
bone
begin
was
with.
there?
Yes.
At least up
Oh,
to.
I never thought of that.
At least up to the root tips of the adjacent teeth.
Yes.
So let's say this is the 8 and this
So
is
you
the
just-
3.
Yes.
Between these there was bone because that's where the teeth
But
were.
why did the bone? Why was the bone
The
loss?
teeth were removed a long time ago.
Yes, yes.
And the pneumatization is going to happen.
Correct,
The membrane is going to keep pushing as the patient breathes
Correct.
against the bone and there's going to be
Yes.
resorption.
No, and thanks for the answer. And another last thing I want to ask you is, you said the system is very simple and very good. Which system of implants are you using?
We are using Dentsply, Ankylose and Zyme.
Ankylose, that is what I was thinking of. Yeah. So Ankylose is good.
Ankylose is very good.
It's very good. Okay.
Very, very good. This
Okay.
welding is just
Now,
very
what-
small part of it.
What is this welding?
But-
I don't understand. What are you talking? I mean, I know that you place the implant and you place the temporary. Now,
Yes.
what is the where's the
Did
welding?
you see the wire in the middle? That's a titanium wire that joins all the implants together.
Correct.
And that is welded in the mouth. Otherwise, how do you give an immediate restoration to the patient which has metal inside?
You give an immediate temporary, no?
But it has metal inside.
Yeah, so it's a
And it's
very
rigid.
good temporary. It's a very
So
good
you got
temporary.
1, 2, 3, 4 implants.
Correct.
If you just give an acrylic temporary, which you can,
Yes.
the acrylic temporary is not rigid. It's flexible.
Right, so you
It's
made
going to
it-
flex. If
Yes.
it flexes, there's going to be movement, micro movement, and the implant is going to fail.
Yes.
You don't want micro movement, so you're going to have to splint the implants with a rigid connector.
Yes.
What is rigid? Either put a metal which is cast, which cannot be immediate because you'll have to take an impression, send it to the lab, get that cast, bring it back, check the fit. That's going to take months. It takes weeks to send the impression. How fast can he give you the casting that fits on a screw? It takes 4 or 5 days minimum. It should. My lab takes 5 days. It can't be immediate. Then that's very early loading. I want immediate loading. I need to fixate the implants
Right.
together now with a rigid wire
Right.
connected rigidly
These
to
are
my
technical
implants.
aspects of implants which
So we
a
need-
non-implantologist
So
won't
we
understand.
need to
Yes.
get a better than castable fit.
Yes.
So you can only have it in the mouth.
Correct.
So we put a wire, we weld it in the mouth, and it's better than your castable.
Doc, the course.
There's a lot of evidence for this.
I'm sure it's
This is
good.
very new in India, but
Oh.
it's been done for last. I mean, there are 12-year prospective studies that are coming out of Italy. So they've been doing it for years. It's
Right.
just that it wasn't available here
Right.
because you don't have implant systems other than Dentsply with weldable copings. If I'm using any other implant system and they don't have a coping I can weld, I can't use the welder.
But Doc, what I'm saying, no?
They'll all come out with it now.
Doc, the course that you did in NYU, no?
Yes.
That is like a 3-year course? Or?
No, that with me it was a 6-month course.
You can do that.
Just 6 months. Because Dennis Tarna was used to teach. So I learned with Dennis Tarna. Perio, you must have learned Perio, right? Tarna and Fletcher classification सुना है? नहीं.
Tell me what you say.
So Dennis Tarna was our teacher. So 6
In
months was
NYU you
in-
mean? And is it like very expensive? And you can do it after BDS?
Now it's become 1 year.
Huh.
It's an international students program.
Okay.
I don't know how much it costs now, but it costs a bomb then. It must be costing a bomb now. Tarna is shipped to Columbia, so I don't know whether it's worth going to NYU anymore. You can go to Columbia, but I don't think Columbia is an international program.
So you can do it after BDS?
Yeah.
And it's easy to get admission.
If you pay, you should get.
Doc, approximately when you did it, how much would it cost?
I think it was about staying there for 6 months was.
Staying is the
I
problem.
used to stay in Manhattan, so it was expensive. But I would say 25-30 lakhs. Now,
Just for 6 months, yeah?
people are paying 30 lakhs for PG.
Yeah. No, but
And then they know nothing. I'm sorry to say.
Dr. Shankar Iyer, no, he's conducting a course,
Yes.
which he's also conducting that implant course.
Yeah.
Also in UAE, also he's conducting. I was in the UAE
Yes.
for 10 years. He was conducting it there. I've not done it.
Yes.
He's doing it for for there as well. And I think probably in India, I'm not sure. I forgot the name of the course. You know, he's conducting it.
He does it with Dental XP a lot. I don't know exactly which one. But I know Shankar very,
Okay.
very, very well. I
Okay.
practice in Elizabeth in New Jersey.
Okay.
I've been in the office couple of weeks. He's
Oh.
a nice guy.
Okay. His wife is my classmate,
Oh,
Preeti. Yeah.
so you have the best connection.
Oh no, not a connection or anything. Just happens to be my classmate. That's okay.
That you say they'll
Sir, I have a question regarding the
You
graph.
have the right contact center in the right place.
Absolutely.
Regarding the graph that you use. what
Thanks
is
a lot,
the-
Doc. Thanks.
Yeah.
Thanks a lot.
More than your technical knowledge.